Good afternoon and welcome everyone to the Commonwealth Club. I'm Gloria Duffy, President and CEO of the club, and I'm delighted to welcome you all to this important program exploring the societal trauma we're experiencing now during the era of COVID-19. In the Bay Area, the Commonwealth Club has suspended its in-person programming, of course, but the club is holding special new virtual programming. You can learn about all of these offerings at the club's website, commonwealthclub.org. We appreciate you considering donating to the club, and if you wish to do so, please text the word donate to 415-329-4231. This helps to support all of the virtual programming. To our audience watching, we want you involved. If you'd like to submit questions, please submit them via the text chat area. Please also share and like this program on Facebook, Twitter, and Instagram. Today's program is underwritten by Kaiser Permanente. It is the fourth in the Commonwealth Club's Thought Leadership Series, together with Kaiser, which is called Destination Health, focusing on the future of health, featuring in-depth conversations on the challenges driving physical, mental, and social health. Today, during the ongoing pandemic crisis, when the impact of inequities in healthcare are particularly profound, we'll discuss what can be done to combat the physical, psychological, economic, and social aspects of inequity in healthcare in order to foster more equitable and healthier communities. We have a terrific panel with us today. Dr. Joseph Betancourt, a physician, Vice President and Chief Equity and Inclusion Officer at Massachusetts General Hospital. Dr. Aletha Maybank, physician, Chief Health Equity Officer and Group Vice President of the American Medical Association. Dr. Lena Wen, emergency physician and visiting professor of health policy and management at George Washington University School of Public Health. And Dr. Ronald Wyatt, physician, vice president, and patient safety officer at MCIC Vermont. Our moderator today, April Dembosky, is health correspondent for KQED Public Radio in San Francisco. To frame the issue of equity in healthcare, I am now so pleased to introduce Mr. Gregory Adams, Chairman and CEO of Kaiser Permanente. Welcome, Mr. Adams.
Thank you, Gloria, and welcome everyone. Thank you for joining us for this virtual panel. Kaiser Permanente is pleased to partner with the Commonwealth Club in offering today's event. Kaiser Permanente is an amazing organization that's been around for some 75 years. And for 75 years, if we look back at our history, we've been on a path and a journey to really embrace diversity, inclusion, and social justice. And yet this past year, with the events that we've seen, the death of George Floyd, Breonna Taylor, our country and the world really sees this as a moment for us to stand up and examine who we are and where we are on the journey of inclusion and diversity. And as much as we've stood and have advocated, it was an opportunity for us to step back and to really examine our organization. I made a commitment to the organization that we would look internal, we would understand where we might have issues of systemic racism, of bias, and we've been on that journey. I listened to, some 20 of our business resource groups and was amazed and actually concerned about what I heard in our organization as we talked about individuals and their experiences. We also made a commitment that as we developed a plan to own what we saw in our organization, that we would also stand up, look out, and be a voice for greater diversity and inclusion in our society and as a corporate organization. During this pandemic experience, we've all seen the fractures that exist in our society, Black and brown communities, others that are marginalized. And yet during this period, we've also seen the opportunity to look at ourselves and look at what can be accomplished with renewed commitment and renewed enthusiasm. I've said to our leaders that as much as people are on the streets advocating, marching, that we've got to be as diligent and as focused in the boardrooms and in our leadership rooms and meetings in terms of what we are committed to. Through this process, we've completed a strategic plan, believe it or not. And in that plan, we've made a commitment to elevate diversity and inclusion as we've elevated quality and safety. We've also made a commitment to focus all of our quality measures and to develop them in a way that they include equity, that they include gender, that they include race, but also that we bring in social issues into how we understand our quality and our outcomes. I think it is a new day and an opportunity for all of us. And I look forward to continued partnership with the Commonwealth Club and to partnership with all of the communities that Kaiser Permanente is in to make sure that we are owning equity, inclusion, and justice in a way and with a commitment that we as an organization and that we as a society have not owned it in the past. So I'm excited for the panel. I'm excited for where we are today. And I'd like to bring April and the panel onto the screen to really kick off this exciting program. So thank you all.
Thank you so much. It is such an honor to be here, and I am so glad that we are discussing this topic, especially with these four experts who I am pleased to introduce in a little bit more detail. Dr. Joseph Betancourt is an internal medicine physician as well as Vice President and Chief Equity and Inclusion Officer of Massachusetts General Hospital. He is also founder and senior advisor at the Disparity Solutions Center at Mass General and associate professor of medicine at Harvard Medical School. Dr. Betancourt is a nationally and internationally recognized expert in health policy, healthcare disparities, diversity, and cross-cultural medicine. He received his medical degree from Rutgers Medical School and holds a master's degree from Harvard School of Public Health. Dr. Aletha Maybank is a pediatrician and Chief Health Equity Officer and Group Vice President of the American Medical Association. Prior to joining the AMA in 2019, Dr. Maybank was founding Deputy Commissioner for the Center for Health Equity at the New York City Department of Health and Mental Hygiene. The center became a model of success recognized by the CDC and the World Health Organization. Dr. Maybank holds a medical degree from Temple University School of Medicine and a master's degree from Columbia University School of Public Health. Dr. Lena Wen is an emergency physician and visiting professor of health policy and management at George Washington University School of Public Health. She was also a medical analyst for CNN and previously served as Baltimore's health commissioner. Last year, Dr. Wen was named one of Modern Healthcare's top 50 physician executives, and she is one of Time Magazine's 100 most influential people. She holds a medical degree from Washington University and was a Rhodes Scholar studying health policy at the University of Oxford. And Dr. Ronald Wyatt is Vice President and Patient Safety Officer at MCIC Vermont. He is former Chief Quality and Patient Safety Officer of Cook County Health in Illinois, and he previously served as Medical Director in the Patient Safety Analysis Center at the U.S. Defense Health Agency. He's an instructor in the School of Health Professions at the University of Alabama, Birmingham, with a focus on health equity, patient safety, and quality. Dr. Wyatt was born in Selma, Alabama, and his family relied on public health clinics for preventive health services. As a child, he saw a general practitioner whose office was segregated by race, and Black people were walk-in only. Dr. Wyatt holds a medical degree and master's degree in health administration from the University of Alabama. I am pleased to welcome all of our panelists. Dr. Betancourt, I'd like to start this conversation with you looking at the situation we are in right now with the pandemic. And you have been charged with leading the COVID-19 response at Mass General. And from the very beginning, before we really even understood how the coronavirus was transmitted, you anticipated that communities of color would be impacted disproportionately, as I'm sure all of our panelists anticipated. And I wanted to ask you, how did you know this and how did you prepare your hospital?
Great, thank you, April, for the great question and pleasure to be here with you. And it's great to see my friends and colleagues, and I appreciate everybody taking time to join us in this conversation. I think history has been our best guide and how disasters, both man-made and natural, disproportionately impact vulnerable populations. Clearly, I think we could just look no far as Hurricane Katrina and how that natural disaster disproportionately impacted communities of color, low-lying areas, levees that weren't kept up well, the impact of race, structural racism, what we call the social determinants of health, which really are vestiges of not, kind of choice of where people want to live in the circumstances that put their health and wellness at risk, but really I think an evolution of a whole series of oftentimes very deliberate policies and practices that lead to, quote unquote, the other side of the tracks. And as history has told us time and time again, these populations suffer at much greater rates from these types of disasters. So we anticipated, we had our surge quite early in March of this year, and we anticipated that this would impact communities of color disproportionately. And we quickly tried to do things that I would argue brought together a doorstep to bedside approach to addressing the pandemic for communities of color, not just focusing on ventilators and bed capacity, but really mitigating spread in these same communities that I think have these factors that create a perfect storm that have been talked about for months now, which include multi-generational housing, densely populated areas, essential workers, the need for public transportation. Before, we were telling people to mask, language barriers, concerns around immigration, mistrust. I mean, these factors in many ways became instrumental. The proof is in the pudding. And we tried to address those in a variety of ways through community health efforts, mitigating spread by delivering care kits and creating isolation sites for people to safely isolate, to increasing testing and broadening testing criteria when testing was a scarce resource, to in our hospital, when we saw that 40% of our patients were Spanish speaking, and outstripping our resources of interpreter services, standing up a group of 50 native Spanish speakers, including myself, who worked with our surge teams to make sure that there was always a Spanish speaking doctor with every interaction with every COVID patient, to providing information in multiple languages, to setting up a text messaging platform for patients and employees who have trouble getting information through some of the standard channels that we who are more privileged get them. So those are just some of the things, April, that we did. Happy to talk more, but we tried to take a comprehensive approach. We tried to, literally throw a lot of things on the wall and see what would stick, see where we could have impact. We used strong public health principles and I think principles around the elimination of disparities to drive our work, and we did the best we could.
Yeah, I remember talking to a lot of doctors early on in the pandemic who were, discussing how resources were being shifted around the hospital, folks who, maybe hadn't done trauma care or critical care since their residency or their internship, were getting retrained to help step in some of these areas. And it was really interesting to me to hear you say that, the resources that you were looking at sort of redirecting were toward interpretive services.
Yeah, I mean, I think for us, we understood that, I think I'll take a step back and say, you can't manage what you don't measure. And the good news is that we have the surveillance to monitor who's in our hospital and really to monitor our performance. So we collect race, ethnicity, language, highest level of education of every person who enters our doors. And we use that and stratify our quality metrics. By that, we immediately kind of leverage that resource to do surveillance both in our communities and our hospitals. And we did see that 40% of our patients were Spanish speaking. It did outstrip our interpreter services, who could no longer go face-to-face because of our desire to conserve PPE. So we did envision language as an asset, identified Spanish speakers, asked them if they would be willing to redeploy. Individuals from 15 different departments, from trainees to full professors, from 15 different Latin American countries, all stood up and we staffed the surge for 6 weeks. So, and I didn't hear April by saying that we didn't necessarily serve as interpreters. We brought clinical, cultural, and linguistic competence to the encounter. And I think one of the biggest benefits of this is our colleagues really saw the importance of diversity in healthcare and healthcare workforce in ways that they never understood it before.
Thank you. Dr. Wen, I'd like to bring you into the discussion a little bit here. We heard from Dr. Betancourt that his hospital was doing some of this community surveillance, some of the work that we typically think is for, public health departments to do. And it seems, we saw a lot of missteps in the early months of the pandemic around testing and contact tracing that in some ways perpetuated inequities rather than helped to reduce them. And so, Dr. Wen, I was hoping you could talk a little bit about what some of these missteps were and what were some of the lessons that we learned from them.
Yeah, I think in time, we are going to look back, at least I hope that we will look back and do a proper analysis of all the many things that went wrong during our response. And I should say, too, all the things that went right, because there are so many institutions, including the one that Dr. Betancourt helps to lead, that did do so many things that do set us on the right track. But there were also many mistakes. And I think one of the big mistakes is not having a national coordinated plan around many of these issues, including testing and contact tracing, April, as you were mentioning. I know that we can see now the importance of testing, that we had missed the early cases of coronavirus coming into the country. We were so narrowly focused, for example, on people coming in from Wuhan in China, that we missed all the cases that were coming from Europe, from other parts of China, because we didn't have the testing. And still, I should say, many months into the pandemic, still don't have sufficient testing. One case was often the canary in the coal mine, and it often meant that there were many others that we just were not picking up on. And in fact, lack of testing and contact tracing was why we had to resort to the shutdowns in the first place. And then because we were not able to ramp up testing and contact tracing enough, that's also why we got to where we are, that with every time you have mitigation measures that then were able to suppress the level of community spread to a certain level, but you're supposed to get testing, contact tracing caught up to that point. But since we didn't, every time we ended up having a surge upon a surge. And that's why we're seeing the catastrophic numbers that we are now. In terms of specifically the impact on communities of color, as all my colleagues here know very well, this pandemic has hit certain communities harder than others. And we also know that whenever there are policies that are unfair, that hurt some in the community, those who are affected the most are always those who have the fewest resources, for whom social distancing is a privilege, who don't always have the ability to quarantine and isolate because of fear of lost wages, because they live in crowded multi-generational housing, etc. And so I think the lessons that we take out of this, I'd say one key lesson, other than the obvious, which is having this national coordinated response and clear messaging, etc. But I think another clear message is the importance of tracking and data, specifically making sure that we are reporting demographic data as well. If we had demographic data around testing, for example, early on, we might have seen that, let's say, a community overall appears to have an acceptable test positivity rate. Let's say it's 5% in the community. But if Latino Americans are testing at 30% positive, and African Americans are testing at 20%. That means that there needs to be much more concerted effort towards those communities. And having that kind of drill down demographic information will be really important as we think through vaccine distribution as well, because we would not want for vaccines to be distributed only to the most privileged communities. And having that kind of data transparency is one way of holding people accountable.
And we will certainly move our discussion toward vaccines. I know a lot of people are interested in hearing about that. I had a follow-up question for you about testing. You know, even at the point where we did identify that there were certain communities that were being hit harder than others. For example, in California, in the San Francisco Bay Area, we had an effort that was intended to increase access to testing for low-income communities of color. It was a project backed by a Google program. And even though it was intended for low-income communities of color, they required people to register for an appointment online. And as a result, all of those resources ended up going to white affluent people who came to make use of the testing. And so even when we want to do a good job, there's still these pitfalls, there's still mistakes that we can get made. How should we be on the lookout for those kinds of things?
Yeah, I think it's such a good point. And it actually brings up the point about telemedicine more broadly as well. I'm a big proponent of telemedicine and telehealth, having been a practitioner of it for years. But we also know that when when things that are new and innovative come up, that despite the efforts, despite the best intentions to make it about increasing access, sometimes it could further perpetuate disparities. And so I think part of it is being attentive to each of these issues along the way by speaking to the members of the community who need to be involved in crafting each of these plans that may sound good on paper and may be with the best intentions in mind. But I think had community leaders centers been involved in some of these efforts, they probably would have pinpointed the problems. I mean, for example, there have been other efforts across the country where getting a test may require a doctor's note. But if you don't have a physician, then you're also going to be left behind. Or drive-in centers are great if you have a car, but if you don't, might there be other settings in communities that might drives at churches or something else that might actually, or testing at churches that might actually get at that more. So I think being attentive to the access issues and not just the principle of it, but recognizing the practicalities will be really important. And I know this is not the time to discuss it, but just as we think about vaccines, I'm hugely concerned about what that might look like as well, that the great principle on paper doesn't translate to the practical reality.
Yes. Thank you, Dr. Nguyen. Dr. Wyatt, I'd like to bring you into the conversation to talk a little bit about how we got here. We've been hearing from Dr. Betancourt and Dr. Nguyen about how some of the inequities in our healthcare system are manifesting during the pandemic. And as we heard in your bio, you went to a segregated doctor's office as a child where Black patients could only get walk-in appointments. I'm hoping you can give us the historical perspective of how racism got baked into our healthcare system.
Sure. Thank you, April. And again, it's an honor to be here with my colleagues to share my thoughts about these topics. So I think we have for too long been ahistorical, and we need to go back through I would just describe it as the pain of history to understand where we are now. And we talk about Henrietta Lacks, we talk about Tuskegee, but I'm talking about really going back beyond that. So when I talk about this, then I'm talking about going back to 1492, and I'm talking about going back to 1619. So when we think about pandemics, then I would say the original pandemic in the U.S. started in 1492 and 1619. That was when Black and Indigenous people and other people of color became the essential workers. The idea of social distancing, from my perspective, started when Black people were chained in the bottom of a slave ship that sailed the Middle Passage, where millions of Black people died. And they became essential workers in sugarcane plantations in the Dominican Republic, the tobacco plantations in Virginia, the cotton plantations here where I am in Alabama. So this pandemic that we're in is not an anomaly for Black and Indigenous and people of color populations. That goes through the times of slavery when Dr. Cartwright described a condition of Black people that he called drapetomania, which meant that you had to have a mental disorder as a slave to want to run away. That goes through the retribution, peonage, Jim Crow, when W.E. Du Bois wrote his treatise called The Philadelphia Negro, and he described what he called a peculiar indifference to the Black populations in Philadelphia. And then that goes to where we are through Jim Crow, up to mass incarceration, which is now called the new Jim Crow. So I would say that this pandemic that we talk about now should not come as any surprise. All of the signals were there. They were not anomalies. And from my perspective, it's almost fatalistic to say, well, we have these Black and Indigenous and people of color populations who are at higher risk. So they were at higher risk before COVID came to the U.S. And we can use the data. And I so much appreciate Joe and Dr. Nguyen for the data work that they do to demonstrate this. That data was there, and I think in many ways underappreciated. Those were the signals that if we get hit with something like this, then there are populations that were already devalued, that were in many ways dehumanized, that there was allocations of resources that were allocated in an unjust and an unfair way that then leads to these outcomes that we see. And these outcomes that we see now in this pandemic really are systematic and they're systemic. They reflect institutional and structural racism that existed before COVID. And many organizations, institutions, and dare I say leaders knew this pre-COVID. So it should not come as a surprise. And as I say, the canary in the cave mine for COVID was already deeply short of breath before COVID hit and was ignored. And we have to understand why these signals were ignored. Why were they treated with such indifference? Why were there 8 or so zip codes in New York City that stood out as very different when COVID hit New York City? And I was there during that first surge of it, and then how it spread across the country. So back to Joe's point then, when we think about what we like to now call the social determinants of health, they are not new. This is the stuff that's been killing us for hundreds of years. And those things have made Black and Indigenous and people of color populations disposable. People who live in sacrifice zones, who are impacted by environmental racism, segregated housing, underappreciated jobs, and the list goes on. Underneath that, I do believe that a core to this from this our profession is a lack of respect, inadequate compassion, and the stripping of dignity from people of color, Black and Indigenous populations. So if anything, this has taught us, don't ignore these signals and assume that they're somehow anomalies. You mentioned the work that I did when I was at the Defense Health Agency. I was on the federal, inside a federal group that had a playbook to respond to a pandemic. We went through scenarios. Where were the supply chains, the federal stockpiles, how to handle transportation, distribution. That was a complete playbook that for some reason I would say is systematic, was ignored, and now we're playing catch up. And we'll get into some of the catch up later. But if I begin to think about what's driving this in Black, Indigenous, people of color populations, it is mistrust, it's distrust, and it's a lack of trust that is historic. And for us to move forward, we have to remove this ahistorical thinking. We have to remove what's been called a myth of meritocracy. We have to somehow find how to show value in these populations that are so impacted by COVID, but pre-COVID. And then how will we, particularly now going forward, begin to allocate resources to the places where they're most needed, not where they're most wanted, but where they are most needed. And the data that Joe has, the data that Dr. Nguyen has, the data that Aletha's working on at the AMA is just a roadmap to show you where to go to do work that can be sustainable. So that this is more than just a moment. This has to be more than a moment. And we have to be mindful of that. I'll stop there.
I think we may have lost our moderator.
So we lost the moderator. I think Aletha, you were next.
But I think Dr. Maybank, you are up next, and so maybe you can give us your reflections based on what we have.
Yes, I'll flow with it. I'm pretty sure the next question was probably going to build upon, and it's kind of building upon the history and the context of race and racism in this country, and getting asked about, that medical students have been taught that race is a biological construct rather than a social one. And if I could explain some ways that this idea permeates our healthcare system, and is actually even built into the tests and the algorithms that doctors and the healthcare system use to determine how to deliver care, what types of care people should have. And I would start off by saying that it's not only medical students really who have this notion that race is a biological construct. This is really an American belief and is also very much rooted in our history. And, it's the belief and actions that races are biologically distinct groups that are determined by genes. And this is known as racial essentialism, but it really has no scientific basis. Our genome project, the Human Genome Project of 2003 that was complete then, really told the science community that we are genetically more alike than there is variation. The variation is very small. But this belief has really, gone across generations, and it has really created harm. And I think just a little more context, because I'm not sure how well informed everyone is around the race conversation. I think it's one of the barriers that we have in this country, is the analysis in terms of structures and systems of power. We have a hard time talking about race and racism, but what's nice to see now and hopeful to see now is that more people are building that analysis. But race, really was documented as a concept developed in the 18th century to really divide human beings into groups, really often typically based on their physical appearance, their skin color, but it also could be social, cultural backgrounds. For those who have been in data for a long time, when you look at old data sets, you'll see Italian was a race, being Jewish was a race. And so race actually has evolved over time. And it really has been used to establish social hierarchy and at one point really ultimately to enslave human beings. And it doesn't really describe, race itself doesn't describe the complexity of genetics or ancestry. And genetics and ancestry are really very distinct terms. And ancestry more so reflects, I would say, kind of our human variations that are due to kind of geographical origins of our ancestors, but that's different than race. Race is merely a social and political construct. As I said, has changed through time. And we even know our US Census changes the definition of race almost every 10 years or so. And so race has use in the sense of what was been talked about so far in describing what is happening to people, race and ethnicity and to communities. And so it's not that we shouldn't collect information on race, but we have to be very careful of how we use that data to generate solutions as well as treatment. And we really have to look at the impacts of racism as a system. And just for that definition, and this is Kamara Jones' definition of a system that structures the power, that structures opportunity and assigns value based on skin color, advantaging whites and disadvantaging people of color. And it's that system that we have to have a better sense of what is happening, the impact of that system on race. What is happening to people we have to better understand in the healthcare system. So the American Medical Association this past November passed policy. One on racism is a public health threat. The second policy was to actually rid healthcare of racial essentialism. And the third was to eliminate race as a proxy for genetics, ancestry, and biology in medical education, research, and clinical practice. Because what medicine and the health community at large has really done, whether it's intentional or not, it has made treatment decisions based on race, which again has no biological basis for disease. So what race-based medicine would tell me is that, I as a Black person, if I go into a health center and I need to do a test for my lung function, spirometry as they call it, or my renal function, my kidney function, and they're going to look at the rate of filtration. If I were to deliver a baby and I would be evaluated based on being Black and whether or not I had the ability to, if I had a C-section before, if I would be able to kind of deliver that baby vaginally. And so my treatment would actually be adjusted differently than that of a white person. And what this says is that something is different about my lungs and my kidneys and my ability to have a baby. And that for some reason it's a biological trait, but that's just wrong. And so these tools, are used on a daily basis to decide, again, like who gets medication and different treatment plans. And they're just unintended consequences that we know cause harm. And we know, as an example, going back to the filtration rates for kidneys, there's a potentially, if I'm identified as a Black person, it could suggest better kidney function. Therefore, if I have a higher filtration rate, it may delay the kind of specialty care that I get, or delay me getting kidney transplantation. And so these are the ways in which, right now there's much greater interrogation and a lot, really led by med students and residents on how are we using race? How is it causing harm? What are the intended consequences? And what do we need to dismantle this aspect of bias that is built into how we deliver care at the healthcare system? And then how do we also better understand the impacts around the experience of racism and other forms of oppression in this country?
Thank you so much, Dr. Maybank. We are getting a lot of questions about vaccines, and so I'm inclined to turn our conversation in that direction. And by the way, if you have other questions for folks who are watching or listening, please do submit your questions through the chat, and we will get to as many as we can. We are at the beginning of this, massive nationwide vaccination effort. And many health officials have put equity at the center of their distribution plans. They want communities that have been hit hardest by the virus to be among the first to get the vaccine. And at the same time, there's a lot of hesitancy. Dr. Betancourt, maybe I could go back to you and, have you tell us what kind of doubts you are hearing from your patients and what kind of plans are you making to try to counter them?
Yes, so I think we've all stated the obvious, that the mistrust that exists is well earned, historic, and evidence based. So it should be no surprise that communities of color are concerned about receiving a vaccine, just like many people are, but magnified at a much higher level. Surveys are showing that. Common sense will tell you that. And it's a problem that I think we've been thinking about. I assume all of us have been thinking about for a while. How do we begin to start to message to our communities that, we do believe the vaccine is safe. We do believe it's important. We do believe it is the path towards, normal. But it's challenging here because as we're trying to center equity and we're trying to do the right thing, right? We're trying to say, okay, we want to, for example, in Mass General, we're going to target hotspot communities first and vulnerable populations first. These are communities, and Dr. Williams was talking about this, that with the diffusion lag, they never get anything first, right? And so now you're going to come to them and they've been decimated and, nobody's cared for them. And now you're going to say, hey, guess what? We want you to have it first. So there's an inherent challenge that although we're doing it with the right intentions, the real concern here and the misinformation that's bubbling up is very, very real. So it is about messaging, but it has to be done by trusted messengers like the people you see here. It has to be done in ways that people can have some of their concerns alleviated in a culturally competent way. And so messaging is just one piece. The second part is we need to stand up and demonstrate, hey, I'm doing this, but not just doctors, nurses, all role groups doing it together. And this is going to be a journey. And the surveys are telling us that everybody's like, yeah, I'm good with the vaccine, but not me first. Everybody else wants others to go first. Truth of the matter is healthcare workers are going to go first. And so I think we will set the tone, but it's not just healthcare workers, doctors and nurses in our hospital. If we are targeting the emergency unit, our intensive care and COVID units, we are targeting everyone who works there, from environmental services to materials management to nutrition and food services. And so we want to be equitable in those ways. But for some of those people working in those areas, it's going to be more challenging to secure buy-in than from others. And so I'm saying we need to, and are being very deliberate about how we structure our strategy and how we actually carve out time and space to make sure that our most vulnerable within our walls, who are healthcare, part of our healthcare team, are able to get the vaccine and not left behind.
I've been reporting on this a lot. I've been attending some committee meetings that California is having where they are discussing, after healthcare workers and residents of long-term care facilities, who comes next after that. And in California, there are some really interesting discussions led by advocates, but also by our officials who are talking about trying to incorporate historical injustice in the consideration of who gets the vaccine first. And they're basically saying maybe by prioritizing some groups, it could be a way of redressing past harms. And Dr. Wyatt, I wanted to ask you, how do you see this? Do you see early access to the vaccine as a way of potentially healing relationships with communities of color?
Yeah, I see it as part of that. And first, I'll reference the Kaiser's Undefeated survey that tells you a lot about what we need to know. When Black women and Black men say this is not a good time to be Black. So we need to start to think about how to overcome that feeling. It is a feeling. It's a feeling that's born out of, and I'll say it this way in a very personal way. It's a feeling born out of lack of love, lack of respect, and lack of compassion. So when we rush in and say, now we want to love you and show you compassion by giving you the vaccine, we got to do more than that. And that work actually should have started back in the spring, not now, because for many people I've talked to, including the call just before this one, it feels rushed. So there's a lot of work to be done, and we've got to demonstrate in a very vulnerable way. And as we call it, we got to practice vulnerability with these communities, with these populations, and go into those communities and sit and listen and ask for permission, and do that with respect and do that with humility. You know, I go to my young barber when I lived in Chicago there on the near west side, and I asked him a simple question. When you go into your primary care doctor, what is the most important thing to you? And without hesitation, he said, I want to feel respected. So can we have some type of truth and reconciliation approach that says, I'm sorry, we apologize, we're going to do better. And we're going to demonstrate to you the ways we're going to do better. That is the vaccine, but it's much more than that, that we're prepared and preparing for and strategizing for, and we will act this time. And we will demonstrate the act, because as I've said many times before, to do this and then to not act in a robust way is a violent act, and it will damage trust even more, and we will have more ground to catch up. So there are people that look like me, that's willing to go out to the community and say, trust me, I will be in line when my turn comes. All too often with Black people that came into my practice, they would say, I will trust you because you are Black. And white patients who would come and say, I will trust you because as a Black physician, I know you had it tougher just getting through medical school. So that's the real conversations that take place in physicians' offices. And there needs to be outreach to the communities that have been marginalized, that have been disrespected, have been ignored, and a robust, rapid response way begin to address all of that. It's always good to start with, we apologize.
Thank you. Dr. Maybank, as an extension of that, as we, talking about building trust and having trusted messengers deliver this message. In California, we had a pastor of an African-American church ask our state surgeon general how he should handle vaccine hesitancy in his community. He said, given the history of medical experimentation on Black bodies like Tuskegee, what can I say to my parishioners to encourage them to get vaccinated? Dr. Maybank, what would your advice be?
Yes, my advice would be totally aligned with what Ron just said. I mean, I think the advice from, as the physician who's speaking or the healthcare worker that's speaking to the community, to start off with one, acknowledging that their fears are rational. I think there's a lot of concern and blame gets placed on people, right, for why they don't do things or why they don't get vaccines or why they don't take medicines. But we need to acknowledge that these fears and concerns are rational. It's a lived experience. We have lots of documentation, right? Our data now shows it really in the science space. So we need to acknowledge and validate that experience. I think to say sorry and we apologize and we recognize how that has caused, how our decisions as an institution and as society has caused harm. And I think as a physician, and I think many of us now who are kind of at we're messengers, do communicate, so I will be taking, the vaccine when my time is available. I'm not a frontline physician at this point anymore in my career. But when that time comes, I believe that the vaccine is safe and effective. There's been tremendous acceleration, understanding, the fears because around the time frame, but there has been lots of kind of checks and balances through this process. And the data tells many of us that this is a safe and effective vaccine. And for that reason, I trust it. And I also acknowledge that I have the privilege to be able to trust it. I've spent many years in school, so I can understand the data. This is what I do, so you have to be able to play that balance of kind of accepting and seeing where somebody is at and meeting them at that moment, and then addressing our own context and privilege. The one thing that I think is really critical that, and Dr. Rhea Boyd says this a lot, she's a pediatrician, and even if we get communities to fully trust, we're not going to solve inequities. We're not going to solve the realities around people not wanting to get vaccines without focusing on the systems and the structures. She says it's not about trust, it's about racism. Racism set up this context of experience. So it's feeling, but it's also a literal experience that's been passed down generations. And so we can't just talk about, we're not going to trust our way out of this moment. We have to really also, if we want sustainable change, then we really got to be focused as systems and messengers on what are we going to do within our context of our healthcare systems, our public health systems, our society around racism, and understanding that that is the root cause of why communities are concerned and why they don't want to get vaccines.
Thank you, Dr. Maybank. Dr. Wen, I want to come back to you because as we've heard now, it's the talk itself is not going to be enough, that we have to actually do something about the system and about how we deliver this vaccine. Dr. Wen, what are some of the logistical things that health officials can do with distribution that will actually, remove the barriers, make it easier for people to get the vaccine?
Yeah, I appreciate the question, but I just wanted to, if I can, reflect a moment on what my colleague said. I really love the comments about how we need to understand, first of all, where our patients are coming from. Those who are expressing degrees of vaccine hesitancy, people are not in the same boat, right? If we ask our patients, and as I've been asking my patients, and the CDC, by the way, recommends in their toolkit that we as clinicians start talking to our patients now about vaccines, even if they're not able to receive the vaccine yet, because we only have it available right now for healthcare workers and nursing home residents. But we should begin the conversations. And it's been interesting to me to see what patients will say as their reasons for why they're hesitant. Many people are saying, this is new. I don't know about this yet. I want to wait a little bit. And, that's a very different answer from somebody who says, I don't think COVID is real. It's not a big problem, and still very different from those who are expressing hesitancy because of historical injustices in their community. And so I think understanding where people are coming from and accepting where they are and meeting them where they are is going to be a really important part of that. I think part of establishing trust is also going to be proving that we are trustworthy. And that also includes being attentive to our patients' other needs. I think going back to something that Dr. White was saying, it's not just showing up and saying, here we have this great magic solution for you, who's going to trust us then, but also to deliver on the other things that our communities are looking for too, I think has to be a big part of this. Another important part that, as has been said, is credible messengers. And I think, April, to your question about the logistical things that health officials can be doing now, it does involve enlisting these credible messengers in the communities and asking them also for how they can be of assistance. I mean, I talked to one of our local pastors who's the head of a Baptist church here in Baltimore, and what he would like to do, and he's been talking to our health department, is can there be at some point, not immediately, but at some point, can there be some kind of vaccination clinic in his church? And he is very happy to be at the very front of the line and roll up his sleeve and get vaccinated in front of his congregants first. And I think, we need to really be listening to the voices of our community and having our health department have the resources very critically to do this work, because the same individuals who have been running testing, contact tracing, figuring out masking and other restrictions, they are the same people who are now tasked with doing vaccination. The state health officials across the country have estimated that we need $8.4 billion to run a successful vaccination program, because this is the largest of such program that we've ever seen in this kind of time period ever in our country, and we need the resources to do that. And so having the resources will also be a critical part of doing that as well. And then I think the last thing that I'll mention is the importance of having practical interventions. And I mentioned this before too, but I think so often when you have people making policy on the federal level, and I don't mean any particular administration, this is not a political statement at all, but rather that there often is a disconnect between federal policies that are set, even state policies that are set, and what one might experience on the local level. And so even something that I'm worried about as an example is when we say that we want to vaccinate healthcare workers as the first group, what does that even mean? Because right now it means that big hospital systems are getting access to lots of vaccines, but people who are home health aides are getting left behind. People who work for smaller rural clinics and even small urban clinics, but that are not associated directly with a hospital are being left behind as well. And so I hope we'll just be very attentive to the distribution challenges. But I think the way we accomplish that is by very critically funding and letting the local health departments that are on the ground lead this work.
Thank you. I'd like to bring in some questions from our audience. We have a question about homeless populations. What can we do to prevent homeless populations from falling further into COVID health disparities, especially in thinking about COVID vaccines? And I think, Dr. Betancourt, I'm inclined to have you answer that question, but if you would rather toss to someone else, feel free.
I mean, I don't want to punt the ball, but I think Dr. Nguyen, in her role in Baltimore, probably, focused a lot on homeless issues and may want to comment here. I'll just say quickly, we have Boston Healthcare for the Homeless. Obviously, vulnerable populations and populations of nature are very, very high risk. And, being able to track, vaccinate, these settings, I think, are high risk. And it's something we've been chasing down since the beginning of the pandemic. And so this strategy is going to require, strong outreach, really leveraging and resourcing well our organizations and our partnerships that we have with the homeless population. But, I'll defer to my colleagues as well here.
Dr. Nguyen, do you have thoughts about, what can be done to reach the homeless population?
I mean, I would definitely agree with what Dr. Betancourt said in terms of enlisting the groups that are already doing this work. Here in Baltimore, as an example, Healthcare for the Homeless is an incredible organization. I know it's in many other places too, but here, I think if that were a priority in the city, then we would absolutely have Healthcare for the Homeless help to lead this type of effort. I would also say that the questioner brings up an important point about how housing has to be considered part of healthcare as well. And I think we have seen that, and I know Dr. Wyatt and Dr. Maybank and others had also mentioned earlier about social determinants. And I think in this healthcare crisis, we have really seen how housing, education, the economy, jobs, right? Everything is interrelated and relates back to public health and vice versa.
Thank you. Another question, what advice would you have for the Biden administration in setting health priorities for communities of color? And Dr. Maybank, since you've been thinking a lot about policy, putting ideas and policy into action, I thought maybe you could answer that question. What advice do you have for the Biden administration?
Yes, without getting too political at it. I think, and we've been working, AMA naturally has relationships with whatever administration is in, and we've been thinking about this in terms of putting forward what are our advocacy and policy ideas to ensure that we're embedding equity and doing it differently. So not segregating like an equity agenda. And I think you can do that, but also how are we looking at everything that's kind of coming like in front of us right now and ensuring that equity is embedded, a racial justice lens is embedded in all of our asks, with the administration as we're talking with them. I think specifically though, we've seen some good movement so far. We already knew there was within the context of their platform, racial justice explicitly. We have never really seen that from a presidential or a presidential-elect administration coming forward to really explicitly name racial justice. So there's potentially a lot to build on. The big part is the accountability to it, and what's going to be put in place that particularly says that they're going to do it and honor, I think, this lens of racial justice. And we see movement. We see Dr. Marcella Nunez-Smith, who specifically, is on the COVID task force, leading the equity part of the work. So that's a tremendous demonstration of accountability and commitment to doing this work. I think, though, moving forward, to make sure that there's going to be infrastructure, and we know there are proposals that have come forward already and ideas around this, to have offices of equity or centers of equity that are not just again, siloed within HHS, the Office of Minority Health, but that kind of move more broadly, and look more broadly, that are in direct contact with the White House and coming from the White House, but also have context across all of the agencies across the federal administration, so that there is equity looked at all of the areas and policies, at the federal level, and to ensure that there's an infrastructure to move forward into this work. And so there's a lot of reframing now around not just equity in all policies and ensuring that, again, the infrastructure and accountability to that, but also even health in all policies, and understanding that for most, and this is the whole context of the social determinants of health. It's kind of a little bit jargony now, but it's to understand that there are health impacts and implications if you don't have housing, if you don't have good quality housing, if you don't have good quality education or good economic opportunity. So that means if we really are interested in a healthy society, we have to understand what are the health impacts of the policies and the decisions that we are making, not only within our health agencies, but throughout our entire government.
Mm-hmm. And one of in understanding sort of, the structural origins of some of these inequities, we also look to the stereotypes and bias that are part of our healthcare system too, and the way that it affects decisions that doctors make and then the care that patients get. And Dr. Betancourt, I know that you have looked at this topic of implicit bias for a long time. How have you seen it play out during the pandemic, and how has the conversation changed over the years about how to address it?
Yeah, it's a great question. I mean, I think ultimately, there's racism, and then there's, this next piece, which is this gray zone that I'd say is, very powerful and very subversive and incredibly dangerous as it relates to the work we've seen around disparities in care, right? It's this idea that, we are all human and we are subject to making assumptions about people as caregivers, that is proof positive, and that does impact care decisions and the way we communicate, and that does impact quality and outcomes. That is no longer hypothesis or conjecture. That's been well proven. And I think that the good news here is that we have over time been talking about the science of this, been trying to communicate to caregivers that we aren't immune despite our best intentions and our best goals here. And the evidence has shown that, yes, we are making progress. 2016, now 43% of doctors now admitting that they have biases that impact their clinical decision-making. How does it play out? It plays out in a case that happened in New York early in the pandemic, where an African-American woman showed up, I think 2 or 3 times with COVID-like symptoms, was never offered a test, ended up, dying. And the question became, was there, a stereotype? Was there implicit bias? Was there racism in how she was managed? And, she kept being told, it's asthma, just go home. You're going to be fine. Just go home. And so those are the questions, April, I think that stick with us. And this issue of implicit bias has been well studied around referral to renal transplantation, referral to cardiology specialist care, the types of care that happens in emergency rooms where people are stressed under time constraints, multitasking, the hallmarks and environment that activates stereotypes. So, there's no doubt that this has played out over the pandemic. It probably still will, and it's going to play out after the pandemic. And we need to continue to really address this head on.
And Dr. Wyatt, I know, I've talked to a lot of different, medical schools and hospitals who are trying to tackle implicit bias with training. And what is your opinion, Dr. Wyatt, about how effective this training is?
Yes, I think it's too early to know. It's not new as a concept, and many organizations use the implicit association test, the one that's created there at Harvard. So I would say that it is a necessary first step, and I would go as far as to say that I would recommend that it be a requirement that you have some type of implicit bias training as a first step. But then what comes next is going to be really critical. And quite frankly, part of that has to be dealing with institutional and structural racism. You have to begin to understand how that operates in medical schools, in training programs, in our institutions. We have to begin to understand that the concept of whiteness is a political construct that needs to be dismantled, and those conversations need to take place as soon as possible, so that we can undo these things, so that we can begin to put in place de-biasing techniques, and those are out there and available that organizations need to start to look at. I've long advocated even that if we have to go the regulatory accreditation route for programs to say, here are some things that you should be doing at a minimum, which Joe mentioned, collecting and validating and stratifying race, ethnicity, and language data, Same for sexual orientation and gender identity data. Same for implicit bias training. The same for interpretive services, and moving beyond, and I don't want to diminish it, moving beyond the cultural competency learning modules, check the box. Now I'm a culturally competent expert. And in many cases, we create people that are more biased when they do that training. So moving toward concepts around structural competency, understanding structural humility, and just humility in general will be really critical to this. And you know, the ACGME is an organization I'm working with. They're already doing this with some training programs, and they're building in this type of training into training programs. So a long way to go, but my hope is that you know, these efforts have started and we can sustain them over time.
Thank you. We are down to the last few minutes. And so just, you know, one last question that I think I'll direct to you, Dr. Wen, and if we have time for the others to chime in with their opinion as well, I think that would be great. But we have a question from a healthcare provider. You know, what can we as healthcare providers do to mitigate disparities that our patients are experiencing?
I mean, I'll start, but I am aware that all my colleagues, we all have other commitments that we must attend to right now as well. I mean, I think even asking the question in this case is really critical, being open and also being empathetic, compassionate with one another as we go through this, I think is a really important part of it, knowing that we are approaching this because we care and because we really want to do the right thing. Not everybody not everybody knows the language. Not everybody knows the right words to use, but we want to get there and we want to be attentive to learn from our patients, from one another, I think is an important start.
Well, I'm afraid that's all we have time for. Let's leave it there. Our panelists are all doctors working during a pandemic. So I want to just thank all of you who attended the program, and thank you to our panelists. Dr. Joseph Betancourt, physician and Vice President, Chief Health Equity and Inclusion Officer at Massachusetts General. Dr. Aletha Maybank, physician and Chief Health Equity Officer and Group Vice President of the American Medical Association. Dr. Lena Wen, emergency physician and visiting professor of health policy and management at George Washington University School of Public Health. And Dr. Ronald Wyatt, physician and Vice President and Patient Safety Officer at MCIC Vermont. We hope today's program has provided some new ways to look at the subject of inequity in healthcare, and we thank Kaiser Permanente for their support of the program. I'm April Dembosky from KQED Public Radio, and now this meeting of the Commonwealth Club is adjourned.
Dear grandparents, because COVID has made it to our family gatherings, we grandchildren promise not to let our guard down.
We'll wear masks in the house, even if Uncle Luis laughs at us.
It's better if he laughs today so that he doesn't cry tomorrow. Mom will use disposable plates because our family is not disposable.
Let's meet up on video instead. I'd rather you not hug me today,
so you can hug me tomorrow.
Don't let your guard down with COVID-19. Hazlo por amor.
My mother died when I was a kid. It inspired me to become a doctor. And COVID hit. No one has ever seen anything like COVID. You feel hopeless. My best friend's father died of COVID-19, then my father caught it. Wearing a mask, washing your hands, sacrifice those things now. You have the power to protect the ones you love.